Hello, I'm Dr. Sohinee Sarkar. I'm a senior research fellow and a principal investigator at the Anti-Infective Research Unit set up by Recce at the Murdoch Children's Research Institute in Melbourne, Australia. I also am a part of the infection immunity and global health team over here, focusing on respiratory infections. Now, I've been working with Recce from 2021, so it's been a few years, and it's a real pleasure to present some of the interesting updates that we have from our lung studies that we have done with Recce's lead candidate at the Anti-Infective Research Unit. Now, Recce really is at the forefront of combating antimicrobial resistance, and today I'll be focusing on non-tuberculous mycobacteria. Now, most people would have heard of tuberculosis, but NTM comprise mycobacterial species other than those causing tuberculosis and leprosy. These are very closely related to MTB, but NTM are primarily opportunistic pathogens that are increasing in global prevalence. And what's of particular concern is that NTMs are particularly increasing in conflict zones and are getting more and more prevalent in infected combat-related wounds. Now, NTMs cause a wide spectrum of disease, ranging from localized skin and soft tissue infections to TB-like lung disease, which can also then become systemic or bloodstream infections. High-risk population groups include people with chronic lung disease, such as emphysema, asthma, COPD, bronchiectasis, and cystic fibrosis. Other groups also include those with immunosuppression, such as people undergoing cancer chemotherapy, people living with HIV, people with a long history of steroid use, those with kidney failure, as well as transplant recipients. And NTMs are also increasing in elderly adults. The problem with NTM infections is that they're usually highly drug resistant. Treatment failure rates are quite high compared to other bacterial infections and can be more than 50% for some NTM species. We're focusing particularly on Mycobacterium abscessus today. This is a cystic fibrosis superbug. Cystic fibrosis is one of the most common and serious genetic conditions, and it's an inherited disorder arising from a defect in the CFTR gene, which encodes for a chloride channel. It's a multi-organ disease affecting primarily the lungs and various organs of the digestive system. In the lungs, due to a buildup of thick, sticky mucus, people with CF end up getting repeated infections, resulting in inflammation, and the repeated cycle of this infection and inflammation leads to lung damage. M. abscessus is an important CF pathogen affecting almost 3 to 20% of people with CF. These infections can be extremely difficult to treat and can further accelerate the progression of lung function decline. Current treatment plans involve cocktails of various antibiotics. Treatment can typically range from a few months, can last up to 1 to 2 years, and these are also associated with high toxicities and high treatment failure rates, like I mentioned, up to 50% in some cases. Now, macrophages and these beautiful cells that you see over here, they're immune cells. They function like the vacuum cells of the body. They're part of our innate immune system. Their primary job is to recognize foreign particles, such as invading pathogens, and gobble them up, and then destroy those internally. Macrophages are a primary target of mycobacterial infections. What these mycobacteria do is once they're taken up by the macrophages, instead of getting killed in there, they're able to divide quite rapidly therein. And they're also shielded from the action of other antimicrobials while they're inside the macrophages. And then they can lyse the macrophages open and then go on to infect other cells. So they're primary intracellular source of infection, an important reservoir that can seed further infection and also lead to recurrence or treatment failure. With the infection model that we have set up, it's a human macrophage infection model with intracellular M. abscessus. And what we have seen that when we treat these infected macrophages with R327 in just 24 hours after treatment, we see a massive decrease in intracellular infection burden. This is more than a 5 log difference, which is more than 99.999% clearance of intracellular bacteria. And this effect is further made further significant after 3 days of treatment. You can see here, after 3 days of treatment, bacteria is really cleared below the level of detection. We have compared R327 to one of the clinically used antibiotics, clarithromycin, and you can see here that R327 significantly outperforms clarithromycin with respect to intracellular bacterial clearance. And what was also really pleasing to see was that we could not detect any host cell cytotoxicity. This is really an important thing to look at, as we know that current NTM treatments, they're all associated with significant side effects. So that is really something we wish to avoid going forward. We also have a mouse lung infection model. Now, because these are opportunistic pathogens, NTM are present everywhere in the environment, ranging from air, water, soil. So most of us are exposed to NTM on a daily basis, but it's really people with those underlying complications that I detailed in the high-risk groups. They are more susceptible to NTM infections. So if we infect wild-type mice, they are rapidly cleared from wild-type mice. So there needs to be this background of some form of immune deficiency if we are to have a valid NTM infection model. So we've gone with TNF alpha deficient mouse model. So TNF alpha is a cytokine. It's made by immune system, and this particular pathway is also dysfunctional in people with cystic fibrosis and with other forms of immunosuppression. So with this TNF alpha mice, when we infect them intranasally with GFP, which is a green fluorescent labeled version of the M. abscessus strain, we infect the mice. It's then able to colonize the lungs and stay there. Because we are able to establish a chronic infection, we are then also then able to test a treatment protocol. In this case, we looked at 7 days of twice daily dosing via a nebulizer. And then we assess infection burden in the lungs as well as other markers on day 11 post-infection. So R327 delivery as a nebulized mist to the lung was really well tolerated. We saw no adverse effects in mouse lung infection. This is really important because not all antibiotics can be nebulized. And then again, they're not all well tolerated when you deliver them directly to the lungs. So it was really great to see R327 being well tolerated in the mouse lungs throughout the treatment period. We did not see any other side effects from routine monitoring over that 7-day time course of treatment. And you can see the mouse body weights over here tracking over time. It's no different to our untreated controls that were just given water, saline, or with the placebo control, or even the intranasal azithromycin, which was a clinical comparator that we used in this group. You may have seen this data before. It was publicized last year, but I'm just bringing it up again just to highlight the amazing efficacy that we saw from nebulized R327 treatment. Again, I do have to mention that azithromycin could not be delivered as a nebulized mist due to solubility issues. This is a major problem with a lot of the antibiotics, while nebulization has greater penetration into the lung tissue, which a lot of the antibiotics cannot effectively reach. Not all antibiotics can be solubilized, and even then they can't be nebulized, or they may not have good safety profile in the nebulized formulation. So that was the best control that we could have in this particular model at the time. And with our 327 treatment, we can see more than 99.9% clearance of the lung bacterial load after that 7-day treatment protocol. I would also like to mention that M. abscessus, like other NTM species, can cause skin infections as well. In fact, it was first isolated from a skin abscess, hence the name abscessus. You can see here on the right a keratinocyte cell line. It's an important and one of the major cell groups of the uppermost layer of our skin. And in this particular assay, we grow the skin cells in a culture dish, which we are then able to infect with M. abscessus. And the way this assay is performed, we can look at extracellular or adherent bacteria, and we can also look at bacteria that have invaded the keratinocyte or the skin cell and gone inside and look at the bacterial burden in both of these extra and intracellular regions. So in our infection model, we compared our 327 with not only a placebo control, but also clarithromycin, which is an antibiotic used in the clinic. You can see here with our 327, just an hour after treatment, there is more than 4 log reduction in bacterial burden. And you can see this reduction is also greater than that offered by clarithromycin. And what was really pleasing to see was that this effect was retained even after 3 days of treatment, whereas you can see the numbers treated with clarithromycin slowly going up. Now, moving on to the invasive or intracellular compartment, you can see here again a similar effect where we see a quite drastic reduction an hour post-treatment, which is then retained up to 3 days after treatment, whereas the clinical comparator there is again creeping up slowly. So overall, this shows that R327 is effective in treating extracellular as well as intracellular infection. So in summary, I would like to highlight R327 as a promising candidate for treating NTM infections. Now, NTM and the diverse species belonging to this particular group of mycobacteria, they can cause a wide range of infections, like I've shown before, ranging from skin and soft tissue to TB-like lung disease. And I hope we have been able to show you that R327 shows promising efficacy against both lung and skin infections caused by M. abscessus, which is one of the most common and highly resistant NTM species. And our lung study data now demonstrates impact in respiratory function, with showing great efficacy and providing new hope for addressing anti-infective challenges in dealing with these problematic group of pathogens. Nebulized R327 can be delivered safely in our model while retaining its efficacy. That's really important to highlight as well. And while current NTM therapeutics are associated with long treatment times and significant adverse effects and high treatment failure rates, R327 presents a viable alternative as a safe and effective treatment option that will improve patient outcomes. Thank you for your time today and listening to my presentation. We are really excited by some of the data that is coming through our Anti-Infective Research Unit in Melbourne, and I look forward to presenting some more updates in the future.